Hello, beautiful people. Welcome to this week's episode of the Montpelier Happy Hour here on WVEW 107.7 LP Brattleboro, your community radio station. I'm your host and producer of the show, Olga Peters, and this is where we talk about how everything in Montpelier shakes out for the rest of us. We are continuing our conversation on healthcare this week, and I would love to welcome to the show regular contributor, Representative Emily Kornheiser from Brattleboro. Hello, Emily.
Hello, Olga. So glad to be here with you.
Glad you're here too, and it was really nice getting to meet our two guests today. I'll start and introduce Marilyn Bartlett. She is a CPA and accountant who's really, her specialty is the money side of healthcare is probably the shortest, sweetest way of saying this. And she has previous experience working with healthcare and benefits for Montana's state employee health program. There is also a presentation that in 2023, she gave to the Green Mountain Care Board on reference-based pricing. And if I can find that again, I will link it in our show notes. Marilyn, I'm so glad you can join us today.
Well, thank you, Olga, and thank you for having me.
And then our next guest, I want to welcome Mark Hage.
Correct.
Yay, okay.
You got it.
And he's the Director of Benefit Programs for members of the Vermont NEA, which stands for National Education Association, and a former teacher as well, also here to talk to us about reference-based pricing. I would love, Mark or Marilyn, if one of you could quickly let our listeners know, what is this reference-based pricing and why might people want to consider it?
I'm going to let the expert answer that.
And I also saw Emily's face. She's like, well, I'm glad she didn't ask me.
Yes. Well, reference-based pricing is tying the amount you pay for a service or supply to a reference point. And typically what we've had with hospitals it began this way, is that what you pay is a discount off of a charge master rate. So that discount is typically confidential and the charge master rate can change. So you don't kind of know where your payment is. So what we like to call reference-based pricing is that you base that reimbursement on another point than a charge master. And what is becoming more common is referencing it off Medicare rates. So instead of paying a discount off a charge master, you pay a multiple of a Medicare rate. So it's more like cost plus, to pay for something cost plus. Mark, what do you think?
I think that's a wonderful definition. And I was just going to add to it, again, something I've learned from Marilyn working with her now for a few years, is that Medicare rates are designed in federal law to be fair, transparent. We know how they're set. They take into account a variety of factors. And I've often thought, again, this is after meeting Marilyn and thinking about the very impressive work she's done, is that if we were to have a conversation in this country about a national healthcare system, and we had to ask ourselves, well, how would we actually pay for services and products? Where would we begin that conversation? I think we'd begin with Medicare because it is a national system. And we do know, again, how those rates are set. And we do try to set them to the best of our ability to be fair, to be rational, and to be sustainable. In this case, we're talking about our hospitals because we want our hospitals to have the finances they need to be able to provide high quality care, but we also want those prices to be fair and transparent. And so I think the work that Montana did back in 2016 under Marilyn's leadership really sort of opened a door for a lot of us to start thinking differently about how we can think about hospital prices here in Vermont and elsewhere.
Emily, I'd love to hear from you. I know you have a question, but my question to you before we jump in is, you were the one who said we're going to be talking about healthcare a lot in the upcoming session, and I need to learn more about it. What is it about reference-based pricing for you specifically that you feel is important to understand and that you feel is important for it to be on the community's radar?
I love that question. I want to answer it. First, I'm hoping Marilyn can talk a little bit more about what a charge master is, because I feel like I just still don't understand that very small detail. And then I promise I'll be big picture.
Oh, certainly, Emily. A charge master is like a list price, and the hospital states those prices. And it's just a list price on the different services that will be provided. And then they offer discounts off of that list price. And it's under the hospital control, and it can change when the hospital wants it to. And a lot of contracts between insurance carriers and TPAs and hospitals will put a clause in there that allows that charge master to increase a certain percent each year without renegotiating.
And why is it called a charge master?
Well, now that's a very good question. I guess it's the master pricing guide. So
Okay.
it's master, and it's a charge rate, not necessarily what you're going to pay.
Oh, it's what you're charged rather than what you're billed. Okay.
Well, and a lot of times you're going to be billed that unless you've negotiated a discount off of that rate. That's a very good question.
So, Marilyn, if I was uninsured and got a bill from a hospital, is it likely I'd be paying what the charge master dictates?
Yeah, it is. We're seeing hospitals now list something called a cash price. So if you're willing to pay cash, it's usually less than a negotiated price, because then the hospital has cash and doesn't have to go through the billing process. But usually if you're not insured or have a negotiated agreement, it's going to be the charge master.
Yeah. You know, Emily, just a little bit of a side note here. Before the federal government changed the law that give you access today to charge masters, I believe under law now hospitals have to provide them. But there was a time when they didn't have to. And right after the law changed, I called a Vermont hospital. I wanted to learn more about these charge masters, these mysterious documents that have a great deal of impact on our lives, but most of us never lay eyes on them. And so I called the hospital. I explained who I was and what I was about. And I said, I'd like to see your charge master. How can I get a copy? And there was this like long silence. And finally the person said, but what do you want it for? I said, well, I'm doing a research project and I'm looking into pricing and I'd like to see your charge master for that purpose. There was another silence. And then, yeah, but what do you want it for? At any rate, we went around and around like this. And finally I said, it was a very civil conversation for the most part. Finally I said, look, it's the law. And I can see this if I want to. She says, yes, but it's very, very long. And it's going to take us a long time to photocopy it. Long story short, I never got it. But they did send me a link to a part of it, right, which wasn't terribly useful. But the secrecy around it and the suspicion around my request was very interesting. It's like, don't look in that black box, right? Don't look too closely at those prices.
Wow.
That's interesting. So, I am, and I think I've said this on sort of every show that we've been focused on this topic. When I first ran for office 7 years ago, the biggest topic that I would talk to people about was healthcare. It was something I knew very little about. I've been lucky enough to actually not have to engage with the healthcare system very much beyond primary care most of my life. And so I went into the legislature like so excited. I'm running for office because I'm going to solve all the problems because no one else knows these things are problems, right? Just my constituents. And this is my favorite joke this time of year because there's all these freshies that feel that way, right? And so, and in Vermont, we had this like really idealistic vision that sort of, dissolved at the very last minute. And so that context also, and a lot of the advocacy around single payer comes from from the Brattleboro area where I live. And so, have been sort of came in, was not in the healthcare committee, and it was clear to me that people were sort of still living in that past failure. Like we tried a thing, the thing didn't work, now we're stuck with what we have. That was like a lot of the political rhetoric 6 years ago. And over that time, we've had a lot of different changes in leadership. We have a new chair of our House Healthcare Committee. And like the crisis has gotten just like so much worse, right? In so many different directions. And so now we are at this point where, you know, Vermonters say every day, like, I both can't get an appointment for the healthcare I need. I can't travel as far as I need to get to that healthcare, and I can't afford either the care or my insurance. So we have like that happening. And then simultaneously, right, we have rural hospitals closing all over the country.
Yeah.
Some because of like incredibly regressive laws, like exacerbated by regressive healthcare laws, like abortion laws, and some because of this sort of like crisis of profiteering um and our healthcare system in Vermont is already like so fragile, right? Like people already can't get these appointments that they need, and our hospitals are struggling. And now it sounds like our health insurance companies are also struggling. Like they're saying that they're in danger of insolvency. And so in a system that like I think the rhetoric is around like someone is profiteering, and if we could just like make sure that we stop letting that bad guy screw us, all the rest of us will benefit. And right now in Vermont, it feels like the hospitals aren't thriving, the insurance companies not thriving, the healthcare providers aren't thriving, and patients aren't either, right? Um, and so like the big bad guy is sort of far enough outside of it feels like Vermont control for us to do anything about that. And so, but we can't nibble at the edges anymore. And so we're at this turning point. What are we going to do to sustain our hospitals? What are we going to do to lower healthcare costs? Because our state, like Vermonters, yes, but also just like our state employees and our teachers, like their insurance is costing such a huge chunk out of funds that we could be using for something else if it was not costing so much. So reference-based pricing is one of those, like, it's one of the magic bullets that keeps on getting tossed into the mix about like, hey, if we just did this thing, it would fix this thing and then we'd be all good. And like, I know it's never that simple. And so I wanted to dive in and learn a little bit more about it.
Thank you, Emily.
Yeah.
So I guess that leads me to Marilyn, a two-part question. One, before we dive in, are there any nuts and bolts about reference-based pricing that you feel people should understand as this conversation goes forward?
Yes, I think that reference-based pricing is a payment mechanism for services. And as Mark talked about, that Medicare MedPAC actually sets the payment rates, and the payment rates are set for a hospital pretty much to break even, except efficient hospitals will have a slight profit. So I never proposed in Montana to pay Medicare rates, that I would pay a multiple of a Medicare rate, but I wanted that rate to be fair. But to me, cost plus was the way I wanted to go. I think one of the important things where reference-based pricing gets confused is that in Montana, we did contracts with every single hospital to accept those rates. If you don't have those contracts, then the hospital can balance bill the member. And we did not want that. So we did contracts with each hospital on that. So it's really, how do you set?
Can you just spend a brief moment explaining what you mean by balance bill?
Yes, balance bill would be that if I didn't have a contract with the hospital and I paid them a multiple of Medicare as the state health plan, but the member received the services, the hospital could charge that member out of pocket that difference between what I paid and that charge master amount. And we did not want that. We did not want that level of disruption. And when reference-based pricing first rolled out, that was the model of just to say, we're going to pay you this and that's it, and the member could be balance billed. But since then, surprise medical billing and other laws have come in place. But I think having it contracted, just to level set it, it's a payment mechanism.
Mm-hmm.
Can you tell us a little? So I think one of the things that's interesting about Vermont and managing Vermont healthcare pricing and policy is like the particular mix that we have in Vermont of sort of who is insured and who are they insured by, right? Like we have a much higher Medicaid rate in Vermont. We have an extraordinary number of Vermonters on Medicare. And then we have a lot of state employees and teachers. And so the people who are, and then for a long time, we've had sort of more people on our exchange than a lot of other states do. But the percentage of folks who are buying on the exchange, sort of the ones that are left that are not Medicaid, Medicare, the ones that are not either federally or like deeply state controlled, right, is a fairly small slice that in some ways it sort of picks up the mess that those other systems leave behind. And I'm sort of curious about your thoughts on that and like how that looks in the context of other states you've seen this.
Sorry, Emily, when you say that picks up the mess, are you talking about like cost shifting?
Cost shifting, thank you.
Okay, thank you.
So much more technical and helpful to describe it that way. Thank you.
I like that. That did level set it. Now, when I did reference-based pricing in Montana, I did it for the state employee health plan and negotiated with every hospital. And so there are 11 acute care hospitals and then 48 critical access hospitals. So every hospital was in the system. So there'd be no balance billing. I did an analysis to see what they truly were making, what truly was the loss on Medicare, what truly was the loss on Medicaid, as there are supplemental payments that come into each one of those parties. So I analyzed the Medicare cost reports for each hospital, and I understood, for instance, one hospital said, we're losing 40% on Medicaid. You can't lower your rate. And when I dug into the numbers, I saw they were losing about 18% on Medicaid, but it was 9% of their payer mix. So that tells a different story. It wasn't a large population they were losing that amount of money on. So I analyzed each hospital to say, what are you making on Medicare? What are you making on Medicaid? What are you making on the supplemental payments that come in? Are there ways that the state can change how those upper limit payments are coming in on Medicaid? I looked at the whole financial picture of the hospital, and there were some hospitals that needed a glide path to come down. They really were struggling with some. I found the highest Medicaid utilization is in our one privately owned hospital. It's not a public, it's not a not-for-profit hospital. And I think that's mostly because of their maternity care. They're really, really top notch on that. And so that was interesting. So I realize I'm not quite answering your question because you're looking at it from the perspective of the whole versus just a segment. And I think that what reference-based pricing gives you a little bit more validity to how you are pricing. You're tying it to something, whether it be the cost, and you can also measure in a particular case if a hospital is struggling, first of all, why? And you can look at their whole financial picture. Have they been, on a buying spree, or what is their administration salaries versus you can kind of get a better picture, and you can work with them to say, how can we come up with a price that maybe is a little bit higher for you for a while? And how can we slowly ratchet down? What can we do to help?
This question of the cost shift, the Medicare and Medicaid cost shift, this is itself could be a whole nother episode.
Yeah.
But For many years now, and I've been working with the Vermont Education Health Initiative, VHI. That's a purchasing pool for all public school districts in Vermont. And we have a handful of private schools as well in the risk pool. And we provide health insurance benefits and other products and services to these schools. And I've been doing this work now as a union advocate for roughly 20 years, a little more. And for a good portion of that time, whenever I or others would ask, well, what's driving these costs? Inevitably, but not exclusively, the argument would be, well, Medicare and Medicaid just aren't paying enough. And so the commercial market has to pick up the difference. And the year that Marilyn presented to the Green Mountain Care Board, 2023, I think, Marilyn, if I recall, there were also presentations by Jeffrey Stensland of the Medicare Payment Advisory Commission, MedPAC, which Marilyn referenced a moment ago, a very smart guy who has spent a lot of his life in the service of Medicare and looking at costs and looking at utilization and other factors. And also Chris Whaley, formerly of RAND and now at Brown University, a very respected analyst. I know Marilyn knows him well, and I have a lot of respect for him as well. And Zach Cooper, Professor Zach Cooper from Yale University. And they were all asked by the Green Mountain Care Board, along with Marilyn, to come and speak to various issues. And what was very interesting was that Whaley, Stensland, and even Cooper both challenged empirically this idea that our hospitals are in the trouble they are or need to charge very high or higher commercial rates because the federal government just isn't doing the right thing. And Stensland and Whaley in particular really undercut that argument. And it's worth looking at their presentations to see how they did it. And again, it's very empirically sound analysis. And the Office of the Healthcare Advocate here in Vermont published a paper that summarized the research on this issue going back several years, and also concluded that the argument that Medicare and Medicaid are simply the culprits here just doesn't hold water, that the research just doesn't support it. And so I didn't know that, frankly, when I first learned of Marilyn's research in Montana.
Mm-hmm.
And yet, over time, because of her work, I began digging into some of these arguments. And what you discover once you're sort of in the mix is that they don't have a lot of validity to them. It feels to me, frankly, I don't want to be unkind, but it feels to me like it's direction through misdirection.
Mm-hmm.
And that the hospitals that are most egregiously overcharging commercial payers will point to the federal government as a way of sort of excusing or coming up with a rationale for why they're behaving the way that they are. But the research shows something very different. And I think that's an argument we're probably going to continue to have. And I'm grateful that the Green Mountain Care Board actually encouraged that kind of conversation.
So where does, and I asked Mike Fisher this a couple weeks ago, the healthcare advocate, when he came on the show. So who is the culprit, to use your language, or like, where is the money going? We have nonprofit hospitals in Vermont. Like, it's not being sort of offshored to some, venture capital firm that's buying up hospitals all over the city, right?
Yeah. Well, nonprofit hospitals, especially the really big ones, have to build margin, right? They don't call it profit, they call it margin.
Yeah.
For-profit hospitals, they will say we're out to make a profit, and they do. Mm-hmm. I think the distinction, that difference between, or the distinction between nonprofit and profit in this regard is a distinction without much of a difference at all. Okay. Marilyn, would you agree with that?
Oh, I would agree. They behave the same.
Yeah.
So where does the margin go?
Mm-hmm. Well, I deal a lot with the audited financial statements, the 990s, you name it. I see a lot going into investments, whether they're buying medical practices. I see them, they invest in private equity. So you really can dig into an individual health system, and you can see that there are a lot of entities under a health system. It's not just the hospital. There will be property entities, there will be joint ventures, there'll be affiliates. So it's no longer really, in most cases, just a hospital. It's a system with a lot of different ownership in it. And I think that you've seen some expansion into these other areas. You've also seen buildup of reserves. A lot of these health systems have very nice reserves, financial reserves. And I always used to hear when I worked with hospitals that they needed financial reserves for a pandemic. But the pandemic came along and it was really funded by the federal government. Mm-hmm. So now what I'm hearing hospitals say is, well, we have to have these financial investments because of cyber attacks. And we've got to build up our cybersecurity. So there's kind of a reason, but I think you got to dig into a particular system and you can look and see their financial assets. You can see what they're investing in, what they're buying, and what they're doing. And then there are also a lot of parties along the way. Insurance companies, same thing. The consolidations and mergers and a lot of them are now taking over revenue cycle management for hospitals, and it gets hard to unwind a lot of that.
Interesting. We have just a couple minutes before we need to hear from some underwriters on WVEW. At this point in the conversation, before we head to break, what do we want to leave listeners with? I leave that open-ended to any one of you.
I think from my perspective, I want Vermonters to understand and believe that we can have a high-quality healthcare system. We can have sustainable, high-quality hospital care, inpatient and outpatient, at lower prices and fair prices, fair to the patient, fair to any payer, and fair to the hospital. We do not have to be locked into this perpetual system of expense growth to the point where large numbers of Vermonters simply cannot afford their health care any longer, certainly can't afford the premium growth. I was looking at Green Mountain Care Board numbers recently from FY19 to FY24. They said premium growth in the commercial market in Vermont exceeded 58%. That's the highest rate in New England. That is not sustainable. It's not fair. And I think there are a variety of ways we can address that problem. And reference-based pricing for our hospital services, I think, is a way of doing that. And again, ensuring that our hospitals have the money they need to deliver high-value care.
Thank you, Mark. Emily, Marilyn, anything you want to add before we go to break?
I just want to throw in a teaser that I'm hoping that after the break, we can talk about how reference-based pricing and global budgeting, which might feel like oppositional forces, could be woven together in a system.
Well said. And I think my takeaway would be, you can do this. I mean, now's the time to do it. I think we have become accustomed to health insurance costs and hospital costs just going higher and higher. Employers feel it and say, well, there's nothing we can do about it. But you really can. And I think now's the time to do it.
Thank you, Marilyn, Mark, Emily. We will all be back right after we hear from some underwriters here on WVEW 107.7 LP Brattleboro. Welcome back to the second half of the Montpelier Happy Hour here on WVEW 107.7 LP Brattleboro, your community radio station. If you're just joining us, I'm your host and producer, Olga Peters, and we have been talking about reference-based pricing in healthcare and what that could mean if Vermont implemented it. I want to welcome back to the show Representative Emily Kornheiser, our regular contributor, Mark Hage from the Vermont NEA, as well as Marilyn Bartlett, who is an accountant and reference-based pricing extraordinaire expert here. Before we dive back into the conversation, I just want to quickly thank Brattleboro Community Television for taking the video version of our show and sharing it with media centers around the state. And Emily, what do we need to remind listeners of?
Well, Olga, the views and opinions expressed here on the Montpelier Happy Hour are those of the host and the guests, respectively, and not the station nor their employer, friend, platform, what have you.
Why, thank you.
You're welcome.
Marilyn, Emily, before the break, had asked about reference-based pricing and global budgeting, how they might marry together. And I do want to get to that. But before I do, I was hoping to hear a little bit more about how reference-based pricing rolled out in Montana and how you took it from this idea to a reality.
Yes, and it was 2014, and the state of Montana Employee Health Plan was headed to bankruptcy. The actuarial report showed that reserves would be at minus $9 million in 2017. So it had to be turned around. And in my career, I had been a controller at Blue Cross Blue Shield. I'd been a CFO for a TPA. So I had learned how to follow the money, and I learned the contracting. So we looked at the only way we were going to get this turned around was to be able to pull money out of the system and not. So I made a commitment that employee contributions would not go up. We were not going to impact the employees in any way, and we were going to provide better benefits. And the only way to do that was to get the money out of the system. The biggest spend in Montana, 43% of our spend were the Montana hospitals. And 87% of that chunk were the 11 large hospitals. I knew that's where I had to go. So I studied their financials, I studied our utilization patterns, and what we decided is instead of reimbursing as a discount off a charge master with your typical insurance company network contracts, we would do our own network, and we would reimburse as a multiple of Medicare. It would be transparent. The Medicare rates at every hospital are known. You would just do a multiple of Medicare. We negotiated with each hospital separately. We knew the break-even point. We knew as a multiple of Medicare with all your other payers in the system, where would you break even? And of course, we were going to pay higher than that.
Mm-hmm.
For hospitals that were suffering and were going to have a hard time getting there, we would pay higher with a glide path down. So we did individual contracts with 11 acute care hospitals and then the critical access hospitals. Some got pay raises, some were reduced, which were system owned. Providers received an increase, the physicians, and everything. We called it transparent pricing at that time because you knew what the price was going to be. You could audit it, you could see it ahead of time. That was it. Hospitals are set up to pay according to Medicare, so it's very easy for you to do a multiple of Medicare payment. We ended up 2017, instead of being minus 9 million, we had 112 million to the good. The legislature passed a bill to pull 25 million back into the state, which it should. It's taxpayer money. Since then, employee rates have not gone up. Since then, they've had enhanced benefits through on-site health centers. And in 2021, the legislature pulled 27 million back in because it became more overfunded. So it added stability and transparency. No hospital suffered through it. There were some efficiencies to be gained, and it worked well.
So thank you for that, Marilyn. I just want to kind of say this back to you to make sure I heard you correctly. When you say we, you mean that the state built contracts between the state and the hospitals and took the insurance companies and said, thank you very much. Thank you for your work. Go to the side. And so that was the contracts that were built individually between the state and each hospital.
And what happened because of Montana law, though, I couldn't contract directly with the hospital. So I had to find an administrator that would contract for me. So the main carriers won't. They want their own network contracts. But it was interesting because we were paying $26, what we call PEPM admin fee then. And when we did our own contracts, and we basically said, we don't need your provider network. We don't need all that cost. And billing was a lot faster, and hospitals got money faster. We negotiated a $15 PEPM admin fee. So it's less work because we took that off of the TPA.
Thank you. Mark, one thing Marilyn mentioned was that this was the state employee bulk of the insurance that was being worked with. And so from your point of view as working with the Vermont NEA, how do you see this working for Vermont and or your members, reference-based pricing, I mean?
So I believe Maryland's pool in Montana was approximately 31,000 covered lives at the time.
Yes.
And the pool, VHI, that I helped to administer, and that's a partnership between the Vermont NEA and the Vermont School Board's Insurance Trust. We have approximately 34,500 lives, give or take. So we're not that much larger than what Maryland did. And when I first learned about the Montana initiative, I began to ask myself, and of course I reached out to Marilyn, who's been very gracious with her time. And I said, well, why couldn't I do this in Vermont for VHI? Couldn't VHI sit down across the table with the numbers, with the expertise we need, and negotiate with particular hospitals here? And she said, well, of course you can, right? But you make sure you've got your numbers, do your analysis, right? And Marilyn is, as you can tell, very number oriented, and I appreciate that a great deal. So I began to think about how VHI could take the Montana template and use it here in Vermont. I also began then to think a little later about what Oregon has done. Oregon is one of those states that has also been inspired by Montana. Colorado and Washington have also moved in their own direction with reference-based pricing for their exchange plans. But Oregon is of particular interest now because they did reference-based pricing through statute. Maryland went hospital by hospital, contract negotiation by contract negotiation. That's a lot of work, as you can imagine. Oregon passed through statute a reference-based pricing methodology that impacts 24 of its hospitals, sets in-network hospital care at 200% of Medicare rates, and I believe out-of-network care at 185% of Medicare. And an analysis of savings for Oregon for the period 2019 to 2021. There are two different studies. One's an actuarial audit. It put the savings at $171 million. The Health Affairs Journal recently published an independent analysis that came in at $107 million in savings for those same periods. So somewhere between those two numbers, I presume, is a number we can probably depend on. Nonetheless, regardless of those two numbers, that's very impressive savings. And if a state like Oregon can do it for 24 of its largest hospitals and take into consideration the needs of other hospitals that were exempted from it, I see no reason why Vermont couldn't do the same here. But to come back to your question, could VHI or any risk pool emulate what Maryland did in Montana? The answer is yes. It requires resolve. It requires a lot of good empirical analysis, doing the kind of research that Maryland did, taking those numbers, and demanding accountability and demanding transparency. And for most pools like VHI, we simply don't have that. We can't look into those numbers the way we should be able to. But it intrigues me. The possibility of doing it intrigues me a great deal, whether we do it one-on-one or whether we do it through statute.
Mm-hmm. And quickly before we hear from Emily, when you talk about it's hard for VHI to look into those numbers, is that just a capacity issue on your side, or are these numbers still really opaque or not transparent somehow?
That's a great question. I think for most risk pool managers like myself, and I don't have Marilyn's background, We are very heavily dependent on third-party administrators, which can be insurance carriers like Blue Cross of Vermont. They are responsible under contract often for pools like ours to negotiate rates with hospitals. So most pools, like the state employee pool, Vermont NEA, excuse me, VI, we don't negotiate directly with the hospitals over our rates.
Hmm.
And we have historically not had the expertise or the capacity to do the kind of groundwork that Marilyn did before she went to the negotiation table.
Right.
And that's a critical piece, as I said a moment ago. But again, there's no reason why, if we were committed, we couldn't get that expertise and we couldn't get the data that we need. And that resolve has not been present. But I think, again, what Maryland has accomplished, what Oregon has done, shows us that it's worth putting some effort in to get there.
Mhm. Thank you, Mark. Emily, you were curious about reference-based pricing and global budgeting.
Can I be curious about other things first?
Of course. And you can even say, I don't want to talk about global budgeting anymore. You're allowed to do that as well.
I feel like I'm being really difficult today. I'm really sorry. So when Oregon did this in statute, was it for sort of all markets or just for their state employees?
It was for the public sector pool, the large, about 300,000 covered lives. So
Okay.
Maryland did it for about 31,000. Oregon's done it for about 300,000. That would be public schools, municipal employees, and state employees. I think there's some public sector units that are not part of it, but the lion's share are.
Okay, thank you. And then are you imagining this would happen through the Green Mountain Care Board, through a decision by VHI? When you imagine, like, Vermont has a quirky regulatory apparatus. And so what would be the clearest path for you to get this done?
Well, thanks to the legislature, we were able to secure an appropriation earlier this year to do a reference-based pricing analysis of our hospital claims. That's VHI and the state employees pool. So roughly 60,000 lives. And that analysis is going to be done this fall under the auspices of the Green Mountain Care Board that's contracting with a vendor. And again, learning from Maryland, before we can move in this direction, we need to reprice our claims. We need to understand the numbers. So that analysis will be available to us at some point in December. And my hope is that we can then move to the legislature to ask that reference-based pricing be done for these public sector pools. And there may be an opportunity to expand those pools to expand reference-based pricing to other public sector employees like the municipal. But the State Employees Association and Vermont NEA are looking to take that analysis and its findings and make the argument that we can lower costs for our public sector employees and their families, roughly 10% of the population of Vermont, and significantly lower costs and be fair to our hospitals. And so I see this as a first important step toward what I hope will be a much broader conversation about reference-based pricing for all of Vermont. And I anticipate that the Green Mountain Care Board will probably be continuing to have that conversation as well. And I hope our analysis is helpful to them in that regard.
Thanks. Okay, so then my question that I had before the break is that we've been moving towards this global budgeting model in Vermont for a few years. And that's something that we negotiate with the feds every few years. We're in the middle of a new negotiation for something called the HEAD model. I have no idea what that stands for. I imagine the H is for health, but I could even be wrong on that. And then reference-based pricing is sort of this other idea that's bubbling up simultaneously. My understanding is that with global budgeting, you're really moving your system away from fee for service and towards outcome-based payments and sort of community health-based payments. And so I'm trying to figure out how those two things would fit together.
I am not well versed on the HEAD model. Are you, Mark? Have you worked with it much? But I think it's interesting to me. I keep hearing move away from fee for service, move away from fee for service. And the American Hospital Association now says that only 6% of payments are fee for service. But they don't consider reference-based pricing fee for service because it's bundled like with DRGs, APCs, and it's not.
What do those letters mean?
Medicare uses diagnostic related groupings. So if you have a person with a certain condition, this is the money you get. And then it's aimed for you to build efficiencies into that and maybe not prolong care. APCs are for outpatient care. It's a grouping. It's called a grouper of what they have done. So they pay in those bundles. I definitely.
Well, poor Marilyn's dealing with a cold right now, so we'll move along the conversation until she can rejoin us again. Emily, before Marilyn joins us again, could you just quickly remind listeners why Vermont considered global-based or global budgeting?
We've been doing it for quite a while. I think we were one of the very first states to negotiate that with Medicaid. And so part of it is that we have just this extraordinarily large Medicaid pool compared to other states. And so it allows us to use our Medicaid dollars in much, much more flexible ways to do more preventative care, and to make sure that hospitals have the resources that they need to be thinking about sort of population and community health rather than just individual patients. So like an example that my hospital system used the other day is that their birthing center, partly because we have quite low birth rates, is not necessarily sustainable on its own. And so by having a global budgeting model, they're able to really see like, what does this community need from its hospital? What should the hospital provide? And do their budgeting from that rather than sort of how much money is coming into each unit, et cetera.
Thank you. Thank you very much. How are you feeling, Marilyn?
Oh, I apologize. I think they can come together. I think reference-based pricing could give some real relief to the commercial segment, that bringing those prices into reasonable range would bring that in. And as I understand with the AHEAD model, you would then have your Medicare population, which could be supplemented with their rates from the federal government. And then Medicaid would be managed too. Now, what I apologize for not being knowledgeable on the AHEAD model, but I think it's the commercial segment that could benefit definitely from that, because what it's really moving to is kind of a cost plus. And then I see your global budget here. So if you're doing cost plus on services and supplies, and you have your global budget, you should have some room for these initiatives that you so critically need.
Mm-hmm.
You know, when I think about global budgets, the kind of global budget that sort of excites my imagination and I think is ultimately doable is this idea of making prospective payments to hospitals based on their historical utilization and their population base, and saying to them, we're going to give you the money that you need in order to service this population of patients. We're going to look at your current utilization. We're going to look at your historical utilization patterns. We're going to look at the intensity and acuity of care that your patients routinely sort of present to you on an annual basis. And we're going to make it possible for you to serve that population. And we're going to help you meet what your real costs are, your true costs. Marilyn talks about this break-even point, right? What do you require on an annual basis to provide high quality care to your service area? Given the history of that service area, the patients that you serve, the conditions that you routinely treat. Reference-based pricing, as I see it, is the opportunity to kind of level set, is to say, okay, what are your actual costs? Let's set reference-based pricing in a way that you can actually meet your costs. And then that would allow us, I think, to establish a foundation for global budgeting going forward. It would also, I think, allow us as a state to address the wild variations in prices for the same services. Auditor Doug Hoffer released a report in, I think it was November of 2021, and he asked Blue Cross Blue Shield of Vermont to provide him with the prices for, I think it was 39 services by hospitals across the state. And the price variations were just all over the map. It made no sense, right? With a reference-based pricing model, again, doing that deep research that Marilyn's been speaking to, we should be able to establish prices across the state that are as close to each other for the same services as possible. So we can address variations in cost. We can get to this question of what your true cost or your break-even point is based on your own reporting to the federal government, right? All of this, again, empirically grounded. And then use that, I think, as a launching pad for building prospective payments. That would be the anchor of a global budget for hospitals. So again, I don't think they're at odds at all. And I think reference-based pricing can help us get to global budgeting.
Thank you, Mark. I see Marilyn nodding along.
I totally agree, Mark. I really like how you explained that. Absolutely, because I would think any global budget has to have a basis in it. It can't be just what you were paid last year and then go up. It has to have a basis of accountability, and it has to be cost driven. So I like how you explain that. Yes, I would agree.
Wonderful. I think what I'm liking about this conversation is, and folks on the regular listeners have heard me say this before, that one of my frustrations with some of our systems, especially around healthcare, is quite often they ask people to make very big decisions when they're in the middle of a crisis. And so I like this idea of more transparency, less all over the place, because, when you're asking someone, do we help your loved one who's having a heart attack, they're going to say yes, no matter what, even if that may not be the best decision in the real big picture financially for them. And so anything that we can making these decisions in the middle of the crisis easier, I always think is a step in the right direction.
Well, I always appreciate when especially when you're talking now about medical debt and the role it's playing in Americans' lives, and surprise billing that, is just out of control when you look at some of these charges, and the legal system has to come in to support it. It's time to make some changes.
100 million Americans are carrying medical debt. That is just a phenomenal figure if you think about it. 100 million American adults carrying medical debt. And our household survey, the Vermont Household Insurance Survey from 2021, found that 41% of Vermonters in the commercial insurance market, so roughly ages 18 to 64, are underinsured. So they have health insurance, but the costs of that health insurance are prohibitive. They're so high that they don't get the care that they need. They can't afford the care that they need, even with that health insurance. So for 41% of our Vermont adults in the commercial market to be underinsured, and to Marilyn's point, so many of them carrying medical debt, the status quo has to change. It has to, right? And I hope the hospitals will work with us to figure out how we do this, beginning with reference-based pricing. We know it's working. We know it can work. It's working in Oregon. It's working in Montana. Other states are doing it. And for the reasons that Marilyn has outlined. And I think we can accomplish the same here. And Vermont NEA and the State Employees Association hope to be informing that conversation going forward.
Thank you. Marilyn, we have just a few minutes left. Anything you want to leave listeners with?
No, I think that this has been a great discussion, and I can understand what Vermonters are facing and what your legislature is facing. These are critical decisions to be making now for the well-being of all of your constituents. And I think it's definitely doable, and it's going to take some creative thinking. And I think the tough thing that I found is that when some people have to give, it's tough. It was tough with some of the health systems in the hospitals that did not want to give, but in the end, they were able to, and it went well, and we were most appreciative. It's kind of has to be a group effort of working together, but it's not easy. But I think you're on the right track. And I like your thinking on a global budget with reference-based pricing involved. I really like that.
Emily is the person who will be going forward and possibly working on some of this policy, or at least the taxes related to the policy. What are you sitting with right now?
I'm sitting with how unbelievably complex this is, and how I want to do a show where we just have a whiteboard and put all the things together. Because it seems to me like the Green Mountain Care Board is already supposed to be sort of regulating hospital prices, right? They approve rate increases. And so how does that, I'm just how does it all fit together? That's what I'm sitting with. And I'm glad we have a few more weeks before the legislative session starts so I can keep on puzzling away. And
The Green Mountain Care Board has rate setting authority.
Yeah, I'm so grateful to you, Marilyn, from bringing this perspective from other states and all your expertise and how long and deep you've been going on this in Vermont, Mark. Thank you.
It's
Thank
Marilyn.
you. Yeah.
Well, that is all the time we have for today's conversation on the Montpelier Happy Hour. You can find us every 2 p.m. Fridays and rebroadcasted on Wednesdays on WVEW 107.7 LP Brattleboro, your community radio station. Of course, wherever you subscribe to your podcasts. And Emily, if people want to reach out to you, how can they do that?
Folks can go to emilykornheiser.org and you will find links to all the ways to get in touch with me, as well as this is our last broadcast before the election. So just want to invite everyone in Windham County or who wants to drive to Windham County to come to our election night party at the Stone Church after the polls close. We're going to have a band, we'll have music, we'll have final results from some elections at least. Don't know which ones. Really glad to have special guest Becca Ballant there, and it should be a great party.
Thank you. Mark, if people, any resources or websites that you want to share with listeners, they might find
If folks want to get in touch with me, I'm at mhage, M-H-A-G-E, at VT-NEA.org.
Fantastic. Marilyn, too, any resources or if people want to reach out to you?
I do think NASHP, National Academy of State Health Policy, is working with different states on global budgets and the AHEAD model, and resources there would be interesting to touch. And on reference-based pricing, of course, I refer people to Oregon. There are a couple of other states we're working with, hoping to roll something out with their state employee health plans. So more to come.
Wonderful. And just before we head out, thank you, Emily, mentioning the election. I'll keep this brief, but I was listening to Stacey Abrams' podcast today, Some Assembly Required, which is a lot of fun. It's about democracy. But she says, when it comes to elections, you see the polls, we talk about the swing states, we do all these things around elections, but the fact is showing up and casting your ballot is what makes things real. So, folks, if you haven't voted early voting yet, remember Tuesday's right around the corner, and please go out and vote. Everyone, have a great weekend.
Thank you so much.